Thank you for joining me today. In this video, you will learn delirium. What is delirium? So let us see it. Delirium is acute fluctuation disturbance in attention and awareness. And it represents a medical emergency. That is the delirium, is medical emergency. The key hallmark is a rapid onset plus fluctuation course and impaired attention. So those are the hallmark. So the role of provider is to identify the delirium early and differentiate from psychiatric disorders and initiate urgent medical evaluation. Since it's emergency, it needs emergency evaluation. Okay, the core features include disturbance in attention and awareness, reduced ability on focus, sustain attention, and shift in attention. So there is a shift in attention and there is a shift on sustaining attention. It is acute onset with fluctuation. Develops over hours to days. So sometimes it happens within hour or within days. Symptoms include waxy and waning throughout the days. That is the classic. Waxy and waning through the day. It has a cognitive changes. These include memory impairment, disorder, and disorientation, language disruption, perception disturbance like hallucination, delusion, disorder thinking. Medical causes include a direct psychological causes and psychosis. So psychological causes and physical causes. Physical causes include a medication, conditions, substance intoxication like withdrawal, and medication. So some medication causes the delirium, some substance intoxication, withdrawal can cause delirium. So delirium is a medical emergency. What are the types of delirium? Type of delirium include hyperactivity, that is the most common. It has the patient will have agitation, hallucination, restlessness, and most people I have seen with this kind of condition is seniors. The second most missed is hypoactivity. Hypoactivity of a delirium is lethargic, reduced activity, appearance depressed. So it appears the patient is depressed, but they are not depressed. They have a delirium, and it's a hypoactivity. They have a low activity. They are lethargic. They have a reduced activity. So most people think that, oh, maybe this person is depressed, but they are having a delirium. There is also mixed alternative between both hypo and hyper. What are the causes? The causes are medical until proven otherwise. It's medical. Delirium is a medical until being proven otherwise. Common causes of a delirium include infection, such as pneumonia or UTI. I've seen that mostly older adults who been already confused and then they develop delirium. Electrolyte imbalance can cause delirium also. Low oxygen can cause delirium also. Central nervous system disorder like stroke or seizure can cause delirium. Some of the medication that can cause delirium include anticholinergic medication, benzodiazepine, opioids, and polypharmacy. If the patient having taken a lot of medication at one time, they can overwhelm the body and cause delirium. Substance abuses that causes delirium include alcohol withdrawal and intoxication. So, what is required? The required is identifying underlying physical causes and interpreting clinical findings across the system. So it's required to assist the patient quick and find out what is causing the delirium quick. Assessment is the key. You want to assess the mostly clinical finding, and features include acute confusion, poor attention, fluctuation of a consciousness between consciousness. It's fluctuating, so it's lethargic. Screening tools include confusion assessment method or CAM. KAM is highly effective. The criteria is acute onset with fluctuation, inattention, disorder thinking, or changing level of consciousness. You want to assess the vital signs, you want to assess mental status, you want to go over and review the medication that the patient is having. Also, you want to check the labs, CBC, CMP, and toxicology screening. Differential diagnosis criteria include delirium with acute fluctuating, dementia graduate and stable, depression with inactive attention. Psychosis don't have a fluctuation. Level of consciousness is not fluctuating if the patient is having psychosis, so that differentiation is different from the other one. What are the treatments? The first priority is to treat underlying causes. You want to figure out the underlying causes and you want to treat that. If it's infection, you want to treat with antibiotic. If it's electrolyte imbalance, you want to correct that. If oxygen is the causes, you want to correct that and give oxygen. If medication toxicity is the case, you want to discontinue the medication. You want to figure out which medication is mostly causing and you want to discontinue that. Most important is interventionists are identifying the causes. So most intervention is first to find out what is causing the delirium, and then you have to treat the causes. Non-pharmacological management is the first line. You want it environmental first, you want to treat the environment, you want to reorientate the patient to the clock, to the calendar, what time it is, what day it is, with whom they are, what location they are, why are they there. You want to orientate the patient. And then you want to give them adequate lighting. You want to light so they don't fall, they don't know where they are. You want them to be awake. Since they are lethargic, you want to figure that out. You want to know if their level of consciousness is going down. So you want to have a light and you want to wake them up to see how awake they are. Sleep hygiene, if they were not sleeping long time and that is causing the delirium, you want to help with them sleep. You want to reduce the noise to lower the confusion and irritation, especially if they are hyperactive. You want to have a supportive care like hydration, nutrition, mobilization and movement, family support. You want to emphasize holistic and environmental interventions alongside the medical treatment. Pharmacology treatment is only if needed. Non-pharmacology is the first line of treatment. So use only for severe agitation, risky to self or others. That's the only time you want to use pharmacology. Behavior pharmacology. Infection, if they have infection, you want to treat the infection. So first line medication with the agitation, hyperactive, will be low dose of antipsychotic medication. Haldol is the most common. Risperdal and Seroquel are the other two for hypoactive delirium. No benzo except if they are alcohol withdrawal delirium. You don't want to give them benzodiazepine if they have any hypodelirium. Only benzodiazepine you can use is when they have any alcohol withdrawal delirium. That is the only time benzodiazepine being indicated. A special case is alcohol delirium, alcohol withdrawal delirium. Benzodiazepine is the first line. Psychopharmacology intervention should target the symptoms cautionally due to the risk of worsening cognitive impairment. Mostly psych medications, they can affect the cognition, and that can worsen the delirium. It can cause more lethargic, more confusion, so you don't want to give psychopharmacology unless it's indicated. Safety management include falls precaution. Since they are confused and delirium, you want to prevent the falls. You want to have a close observation. You want to minimize the restraining. Complications. What are the complications of a delirium? Complications of a delirium include increased mortality, prolonged hospitalization, cognitive decline, and functional decline. Those are the complications of delirium. So delirium is medical emergency. Delirium is acute with fluctuation with attention and attention deficit. So the delirium is acute, and it is level of consciousness is changing, fluctuating, and it affects attention. Most common causes is underlying medical conditions. Hypo, which is low, hypoactive delirium is often misdiagnosed. First line of treatment is underlying causes, not first line of treatment is treat the underlying causes. Antipsychotic medication is the only used when it's severe agitation. Elderly patient is sudden confusion. If the older patient is suddenly confusion, that means that leads to delirium. Fluctuation symptoms during the day can lead to delirium. ICU patient pollen lines is equal to hyperactive delirium. Quiet withdrawal confused patient is equal to hypoactive delirium. Treatment is fix underlying causes first. So if the patient is elderly and they are confused, that could be delirium. If the symptoms are fluctuating and level of consciousness is changing during the day, that could be a delirium. If the patient is ICU patient and pollen lines, it could be hyperactive delirium. So you want to assess that. Rapid recognition of a delirium versus psychiatric illness. Initiate medical evaluation and refer the patient to a specialist if they need to. You want to manage the behavior symptoms. You want to manage the safety. You want to collaborate with other medicine or neurology department. You want to educate the family and team members. Thank you for joining me today. I would love to see you in my next video. Please subscribe and come back.